uh, lymph node assessment in WIMS tumor. Now, the two important principles of WIMS tumor surgery is avoid a tumor spillage, and second, never forget to sample the lymph node. Now, sampling of lymph node is given a very important place in the surgery for WIMS tumor. Why is it so? Because it is a crucial determinant for given treatment. The presence of stage lymph node positivity confers a stage 3 status, and that means we have to add doxorubicin if it was not given initially, and definitely radiation has to be added, and definitely there is an implication. The COG data, which says that of all the determinant of stage 3, the commonest cause of having stage 3 was lymph node involvement alone or in combination with microscopic residual disease. So lymph nodes are an important contributor to the stage 3 disease.
Yeah, which port is asked actually? Any port, like no port closure, direct port
uh,
closure.
uh, can please someone mute the, yeah, okay. Right. And the lymph node, whenever the lymph nodes are present, event-free survival and overall survival are less favorable as compared to patient with lymph node metastasis. Though this is not statistically significant in solo lymph node metastasis, but when lymph node metastasis is combined with microscopic residual disease, it becomes a very small, significant contributor for inferior event-free and overall survival. So if it is so important, why don't we identify the lymph node problem before the surgery? So what's the use of the radiological assessment? With so much advances in radiology, can radiology be used as a tool for assessment of lymph node? Unfortunately, lymph node assessment remains a very not so well demarcated area in the radiological community. The sensitivity and specificity with a cutoff of 7 millimeter was very humbling in one of the study. And even in our study, the interradiologist agreement was the poorest with the status of the lymph node. And the next thing is, if the radiologist is next not able to help us, should the surgeon come forward and iron out the problem of lymph node involvement? Unfortunately, the surgeons are the worst predictors of lymph node positivity. If a surgeon says that lymph node is positive, 40% of the time he is wrong. And same with the false negative rates also. So this is a problem that lymph nodes needs to be assessed well, and the surgeon and the radiological features are not well demarcated. That's why there is a problem. And in fact, because of this, there is sampling of the lymph node is the biggest casualty, and it is one of the commonest surgical protocol violation, and that ranges from 9 to 42%. Even in a trial setting like NWTS5, omission of lymph node sampling was seen in 10% of the patient, and in the real world setting, the National Cancer Database, the omission was in 20% of the patient. So this is a problem. Now, why this is a so big problem? The reasons for this problem, the commonest reason and the most important reason is there is no guide. We say there's sample the lymph node, but there is no guide from where to sample, and there is a problem with the number of the lymph node also. And most importantly, there is poor application of the anatomical knowledge. The patients we encountered wherein the lymph node sampling has not been done, on questioning the surgeon, the operating surgeon, the commonest answer we get is there were no lymph node only. So what should we sample? So let me tell you that God has given around 400 lymph node in the retroperitoneum and pelvis. It is not possible that the lymph node is not there in your index patient. They are there, you have to search for them. So these are some of the reasons why lymph node assessment is a problem. So if we know where to sample, we can get an idea that we should be doing this thing. Though that answer can be given by there have been some cadaveric studies in which right-sided tumors were more commonly the lymphatic spread was lymphatic drained in this area, the paracaval and interaortic caval region for the right-sided tumor. For the left-sided tumor, para-aortic and pre-aortic lymph nodes were the commonest nodal basin. And interestingly, the hilar lymph node were not involved in this small study. There are some clinical studies, obviously not for Wilms tumor. There have been studies for renal cell carcinoma in adults. The lymphatic spread was commonest in the paravascular, the interaortic caval, the retrovascular region, and 29% of the lymph node were present outside the hilum. The hilar lymph nodes were negative, but the other lymph nodes were positive. So based on these anatomical knowledge, we planned this template wherein the midline of the aorta and the IVC were taken, and the two horizontal line, one at the level of the celiac and the other level at the level of IMA, that divided our region aided by the renal vessel into a suprahilar, hilar, and the infrahilar region, and the interaortic caval region between the two midline vascular lines. They were divided into a suprahilar interaortic caval and infrahilar interaortic caval. So these were the template based on the anatomical knowledge and the clinical studies. Based on that, we devised that these should be the template. For the right side, we sample the right suprahilar, hilar, and infrahilar and interaortic caval both. And for the left side, we harvested the para-aortic and the interaortic caval. So 5-station lymph node were sampled from two sides. So we did this study, which was an IRB approved study, and we sampled 5 lymph nodes from 5 stations. The number of lymph nodes to be sampled was not expressed, but each node should be sampled. Even if you're not finding a lymph node, the adipose tissue from that area should be sampled because that might contain small lymph node. The idea is to sample. No attempts were made for a clearance, and no attempts were made for getting the histology by a frozen section examination. All the lymph node separately labeled packets were sent to the pathologist. We had 113 patients with Wilms tumor, and the median age was 3.6 years. 13 of these patients had an upfront surgery. 100 had a surgery after preoperative chemotherapy. 15 patients had a lymph node positivity. If all the upfront nephrectomy patient had lymph node negative disease, the 15 patients were from the 100, so it was actually 15% lymph node metastasis, which is the very well accepted lymph node metastasis in Wilms tumor. So for a right-sided tumor, we got the sites of lymph node metastasis where the suprahilar, hilar evenly distributed on the paravascular side and interaortic caval. Now, important thing was 3 of the patients with interaortic caval lymph nodes had no metastasis in the paravascular region. So these were skip metastasis. On the left side, we had all the metastasis in the hilar node. The para-aortic nodes were not involved, and interaortic caval node was having a skip metastasis in one patient. So 3 versus 1 skip metastasis present. This is the combined picture of both sided together, and hilar station was the commonest, followed by the interaortic caval lesion. The important thing was 26%, almost 27% of our patient had skip metastasis. That means the hilar nodes are negative and interaortic caval lymph node were positive. This is more so with right-sided tumor. And when the lymph node yield, how many lymph node were we able to harvest with this technique? The median yield was 8. For upfront surgery, it was 6, and after chemotherapy, it was 8. Now, mind you that the lymph node yield after chemotherapy is supposed to be less, but we got a lymph node yield of 8. This is probably because of the religiousness. We went and sampled each station. That assured us having a good yield. The median number of lymph node in the patient who were having positive lymph node was 10, and the patient with negative node were 8. So this was there is a tendency for a surgeon who feels that it is a large tumor or the lymph node are large, I do sample more node. So you get more sampling when the lymph node are positive, but this was not statistically significant. And lymph node density, which is the percentage ratio of lymph node harvested and positive lymph node, was 0.16 in our study. As expected, the stage 3 survival was inferior as compared to stage 1 and stage 2. And when we compared lymph node negative patient, it was lymph node positive patient had a worst event-free survival. We also identified factors which predicted lymph node metastasis: tumor size, largest dimension of 12 centimeter, high risk pathology, blastomal predominant and diffuse anaplasia, and vascular thrombus were significant on univariate, but only the high risk pathology with an odd ratio of 12.67 was significant factor in deciding lymph node metastasis. So to conclude, systematic lymph node sampling involving 5 stations provides a template to guide surgeon in lymph node harvesting. And this will minimize the inter-operator variation. Each person knows which station has to be sampled. Minimum 5 lymph nodes are assured. This will avoid false negatives because you may target only the hilar node, but the lymph nodes of other sites may be present. So the sentinel side of lymph node involvement will be identified. And more importantly, you have enough number of lymph node to be scanned by the pathologist. And lastly, inter-aortic lymph node sampling should be performed routinely because the incidence is sufficiently high in this situation, and the metastasis can skip the hilar lymph node. We have published this study in it's in the December issue or December 2020 issue. You can have a look if you have any further questions. Thank you very much for your kind attention.